Going a little bit further down, I want to talk a little bit about hyperthyroidism. I want to talk about etiology. So once we see a patient and they have consistent symptoms and signs consistent with hyperthyroidism, we should think about the most common causes. The most common causes being things like Graves' disease. That's the most common one, especially in young patients. And then the other one that we see in older patients is the toxic multinodular goiter. So that's the second most common one that we see. But we see some other forms of hyperthyroidism. They may not be the type of Graves' disease, but they are clinical. Clinically, the patient presents with hyperthyroidism in these cases too. And this is subacute thyroiditis. I just showed you a case of that, how they presented, or decurvens thyroiditis. That's another name for it. And then there's extrathyroid sources, like thyroid toxicosis factitia, where people are taking exogenous thyroid hormones, and stroma ovari, where these people have these tumors. They produce either T3, T4, or TSH, and excess TSH from the pituitary is very, very, very rare. So I want you to know the Graves' disease, the most common one. The second most common one that we see is toxic nodular goiter. And I want you to remember a little bit about subacute thyroiditis and factitious thyroiditis, because they also present with hyperthyroid syndromes, hyperthyroid clinically syndromes. So Graves' disease, we said, is the most common form of hyperthyroidism. Now, the typical triad that these patients present with is hyperthyroidism plus a big diffuse goiter on the exam, and then exophthalmos. Exophthalmos is clinically, it's called proptosis. It's the same thing. Exophthalmos and proptosis, they're talking about the same thing. And I want to make sure you understand that the Graves ophthalmopathy, the exophthalmos, the proptosis is only seen with Graves' disease. There's no other disease that you see this with, no other thyroid disease. So please, if they show you a picture with the patient with the bulging eyes, they have that kind of like wicked stare, the typical Graves' disease patient, and they ask you what form of hyperthyroidism is this, it's only Graves' disease. It only occurs with Graves' disease, can't occur anywhere else. The typical scenario is it occurs in women, usually in their 4th decade, but it can occur earlier or later, and it occurs sometimes in men. Now, the premise of Graves' disease is that this is an autoimmune disease. You have autoantibodies formed against the TSH receptor, and I shouldn't say against the TSH receptor, I should say antibodies that latch on and activate the TSH receptor. Now, this is important because basically these are the antibodies. They act like TSH, and what they do is they activate the TSH receptors on the thyroid, and that's why you get the diffuse enlargement. It's basically like having excess TSH in the body when you have these antibodies. Now, these antibodies, I want you to remember them because they've asked questions about them. These antibodies are called TSIs, right here, TSIs, or thyroid stimulating immunoglobulins. So that we see those in about 95% of the cases in Graves' disease. And when we have any question about Graves' disease, this is one of the extra tests that we do to confirm the diagnosis. We look for these antibodies, autoantibodies, thyroid stimulating immunoglobulins. So really, Graves' disease is an autoimmune disease, and the nature of the disease is that it comes and it goes, just like other autoimmune diseases like lupus. So it has exacerbations and remissions. Now, these patients also have autoantibodies that cause the ophthalmopathy, the extraocular muscle antibodies. And one of the things that they ask us on the boards is, after treatment, after we treat the patient with Graves' disease, are there any of the symptoms and signs that get worse in a patient with Graves' disease? This is after treatment, after we're treating the patient with Graves' disease, and the answer is yes. The Graves ophthalmopathy, the Graves exophthalmos, the Graves proptosis sometimes gets worse despite treating the patient with Graves' disease. So all the other symptoms get better, but the eye manifestations commonly get worse. And the reason they get worse is because they have a life of their own. There's autoantibodies specific for this disease, and whether they get better or they get worse or they stay the same, it's basically on their own. It has nothing to do with the treatment of the Graves' disease, the primary Graves' disease. Because it's an autoimmune disease, because Graves' disease is an autoimmune disease, we also see it commonly with other autoimmune diseases, like pernicious anemia and myasthenia gravis. So it's common to see patients with Graves' disease to develop earlier or later B12 deficiency from pernicious anemia and so forth. So look for that, because autoimmune diseases, they kind of go together. If you have one, you are likely to get another one. Now, the presentation of Graves' disease is the nervous system, the nervous symptoms, the nervous system symptoms where they get jittery and they have they get tachycardia, like cardiovascular disease, and especially in older patients, they have a myopathy, where they have proximal myopathy, where they have difficulty standing and picking up things. And then they have the tremors and the inability to sleep at night. They may have diarrhea, sweating. Heat intolerance is very common, especially in warm places. And they have weight loss. Typically they have weight loss. Some of these patients, about 8 to 10% of them actually don't lose a lot of weight, or they gain a little bit of weight because they have so much hyperphagia, they eat so much. But the typical scenario, 90% of the cases, is the weight loss. And they sometimes have a form of congestive heart failure called high output failure, which causes the typical heart failure symptoms of palpitations, dyspnea, shortness of breath, and so forth. A couple of other things that these patients have: they may have the palmar erythema, which is typical, and they have a form of lower extremity edema called pretibial myxedema. Now they sometimes ask about this on the boards, because when you hear the word myxedema here, your mind goes exactly to hypothyroidism right away. But this pretibial myxedema, this thickening, non-pitting edema, it's initially pitting and then it develops to non-pitting edema in the lower extremity, usually confined to below the knee, is typical of Graves' disease. So look for that. They show you sometimes a picture, right, and they show you the proptosis, and then they show you the swelling of the legs, just to kind of get you to think about myxedema and hypothyroidism. No, this is a presentation of Graves' disease, so don't miss that. A couple of things for the diagnosis. In most typical patients presenting with the proptosis and so forth, all we need to show is a suppressed TSH, a low TSH, and the free T4 elevated. You don't even have to get free T3. So that's a $300 test that you don't have to get here. All you have to do is get a free T4 and a TSH. The TSH is low, the free T4 is elevated, and in the patient that has proptosis, because I said it doesn't occur anywhere else, in no other disease, then you have the diagnosis and you don't have to go any further. The radioactive iodine uptake is usually not needed. If there's questions about the diagnosis, if the patient doesn't have proptosis, if the patient doesn't have the typical presentation of the big thyroid that's very vascular, then you do the radioactive iodine uptake to see if this patient could have maybe not Graves' disease, but subacute thyroiditis or toxic nodular goiter, or something other than Graves' disease, because it changes what you do for that patient. So the radioactive iodine uptake is needed only in the cases where there's a question about the diagnosis. And if you do the radioactive iodine uptake in the patient with Graves' disease, what you see is diffused increased uptake throughout the whole thyroid. That's important. So if they give you the typical radioactive iodine with Graves' disease, diffuse uptake throughout the whole thyroid. If it's not diffuse uptake and it's nodular uptake, regional uptake, they're talking about toxic nodular goiter. If it's decreased uptake, they're talking about subacute thyroiditis. The thyroid stimulating immunoglobulins, I told you, are the antibodies that we see in these patients in 95% of the cases. And they confirm the diagnosis, but we don't usually need them because they don't help us out a lot. We don't really do anything. Sometimes some people get them to see if the patient has recurrence of disease later. You may do that, but generally for diagnostic reasons, it doesn't help us only in the rare cases. Despite doing all the other stuff, the radioactive iodine, if we still have a question about the diagnosis, we may do the thyroid stimulating immunoglobulins to confirm the diagnosis, but generally speaking, it's not needed. But yes, they're positive. If you do them, they're positive in about 95% of the cases. So if they ask us a different question on the board, what antibodies is Graves' disease related with, and the answer is yes. Thyroid stimulating immunoglobulins, 95% of the cases, they have antibodies that are positive. So we've diagnosed the disease. Now what do we do about it? So the treatment is basically on two levels. One is the immediate, the acute treatment of the disease, because it's basically, symptomatic. We have to take care of the symptoms, the tachycardia and all that. And then the second part is the long-term treatment of Graves' disease. What do we do long-term? Remember, Graves' disease sometimes could be, if not treated well, could be life-threatening. It's not like hypothyroidism, so you have to think about definitive treatments, long-term. So let's do immediate treatment first. What do we do first? We have to do two things. We have to suppress the symptoms of the tachycardia, the high output state, and suppress the thyroid hormones. So the types of medications we give is beta blockers to control the adrenergic symptoms, things like propranolol, atenolol, a lot of beta blockers to control the symptoms, and then along with that, anti-thyroid medications to basically suppress the thyroid hormones. So anti-thyroid drugs used in this country are propylthiouracil, or PTU, and methimazole. Both are equally effective. Some people say methimazole is a little bit more effective. Not only does it suppress the thyroid hormones, but it also suppresses the conversion of T4 to T3 in the periphery. So some people, even though I put it 2 here, like methimazole a little bit better because of this possibility, although it hasn't been substantiated very well, but it is, it is believed that this is the case, and some people like it. And they say, let's go with this because it's a little bit better than PTU. But really, to make a long story short, both of these are equally effective. Now, these drugs are good drugs, but they have one very bad side effect, and that is neutropenia, a granulocytosis. So here's the recommendations. Once you put a patient on PTU or methimazole, you do not have to routinely check CBC count, white cell count to look for a granulocytosis because it's so rare. It is very rare, and so you don't have to do it, but you have to tell the patient to look for things like infections, high fever. And so if that happens, the patient calls you, listen, I have 103, 104 fever, my glands are swollen, I don't feel good. You tell them to stop the medication and come and see you, and you check the CBC to make sure the patient doesn't have a granulocytosis. If this is picked up, and most of the time it is picked up early, and you think about it, once you stop the medication, it's reversible. Almost 100% of the time. The only time it's not reversible if you continue the medication despite symptoms for a long time. That's rare. Most people pick it up. So this is a reversible disease. Once you pick it up, a granulocytosis is totally reversible. If one medication, for example, let's say you're taking PTU, causes a granulocytosis, you cannot switch to methimazole because that will likely cause a granulocytosis too. There's a risk of a granulocytosis when you switch from one medication to the other. So the bottom line is, once you get a granulocytosis with any of these medications, you stop the medication, you got to go to some other type of treatment. Just know about that. So how much of all these drugs do we give? How much beta blockers and how much anti-thyroid medications do we give? Enough to control symptoms. So there is no standard dose. We start low and we start working our way up. So how much beta blockers do you give? Enough for the symptoms to be normal, for the symptoms and the signs and the vitals to be normal. That's basically how much, and that's exactly how much PTU or methimazole you give, basically to make the patient clinically euthyroid and biochemically euthyroid, both. That's when that patient is, you say, this is my dose of the medication and I keep this patient on it. Now, once you make the patient clinically and biochemically euthyroid, that's the time when you start thinking about long-term definitive treatment. And the definitive treatment in this country, once you made the patient euthyroid, not before that, is radioactive iodine ablation. So we give the patient enough radioactive iodine, kind of like not the same one that we gave before for the uptake scan, but the same concept. We give them enough of radioactive iodine basically to blow out all their thyroid cells and basically cause fibrosis of the thyroid cells. So these patients eventually develop hypothyroidism over time. They develop hypothyroidism over time. Over months to years, they develop hypothyroidism. So once we treat the patient with radioactive iodine ablation, this patient doesn't become hypothyroid right away. This patient becomes hypothyroid in months and sometimes even years. Most people say at about 5 years, 90% of the patients with radioactive iodine ablation are hypothyroid. So this is another thing we have to know about clinically, because they ask us on the boards, what do we need to follow the patient after radioactive iodine ablation? You need to follow them twice a year. They have to come and see you twice a year and see when the patient is starting to become hypothyroid. You start to give them thyroid medication so they don't develop, severe symptoms of hypothyroidism. So the treatment, long-term treatment, is radioactive iodine ablation. Surgical thyroidectomy is rarely done in this country and is reserved. We're going to talk about it in a little bit only for the pregnant patient. So radioactive iodine ablation is the treatment of choice long term. Now, they have a question on the boards where they have asked, well, why don't we give radioactive iodine ablation right away? And we have to go through the the immediate treatment with beta blockers and PTU, and then give this guy radioactive iodine ablation years later or months later. Usually it's not years later, it's months later, once we made him euthyroid. The answer is a very active thyroid, if you give him radioactive iodine ablation, the patient's going to get worse. They're going to have all the spilling of the thyroid hormones, right? So you have to suppress it, you have to control it, you have to cool it down, and then give the patient radioactive iodine ablation. So you can't do anything in the very active thyroid gland except suppress it with beta blockers and anti-thyroid medication, and then give it radioactive iodine ablation. I'm going to say this because some people have practiced in other countries, in other areas of the world. Radioactive iodine ablation is not the choice in the rest of the world. It's the definitive treatment in this country because people feel that Graves' disease and hyperthyroidism could be a life-threatening disease. So if the patient stops to take their medication, they have this thing called thyroid storm, which carries a very high morbidity and mortality. So they rather make the patient hypothyroid for the rest of their lives, which is something benign, rather than treat them for long-term with Graves' disease. But you will notice in some other parts of the world where patients are put on propranolol and anti-thyroid medication for a long time. And then if they do well on them, because this is an autoimmune disease, and remember I said autoimmune diseases kind of, come back and they go, and they have flares and exacerbations and remissions and stuff like that. So they treat them for a couple of years. This is done in Europe and parts of Japan. And then after 2 years, if the patient's doing really well, they pull them off the propranolol and the anti-thyroid medication. And these patients actually, they don't get another thyroid flare. They don't get another Graves' disease flare. sometimes never in their life. So that's another way to treat these patients. You'll notice that in other parts of the world, but again, we don't do that here. So I don't want you to go down that pathway. I just want to tell you about it because you may see patients in clinical practice managed that way. And then in some other parts of the world, they do thyroidectomy very liberally. In this country, the chance of getting laryngeal nerve palsy, hypoparathyroidism is much higher than any risks from radioactive iodine ablation. So people say, you know, radioactive iodine ablation is the most cost-effective, best way to treat Graves' disease in the long run, and that's the way we're going to go for the boards. I want to talk about a little bit about Graves' disease and pregnancy. The pregnancy is the only exception to the rule. The only exception to the rule where we don't do the typical treatment. So let me tell you a little bit about this. In the pregnant patient, we cannot use, with Graves' disease I'm talking about, we cannot use methimazole. Methimazole is contraindicated. Some people say the studies weren't done well, that showed some fetal defects and stuff like that. But the bottom line is we cannot use methimazole. We could only use PTU and propanolol. Now both of these cross the placenta. Propanolol at high doses is associated with small dates, neonates and stuff like that. So we can't really increase the dose of the propanolol to where we really can control symptoms. And the PTU, even though most say it's safer to use than methimazole, it's really, that crosses the placenta too. So in high doses, we don't know what effect that has also. So the bottom line is, in the pregnant patient, we use propanolol and PTU at small doses, just enough to cool down the thyroid. If that's not enough and the patient has symptoms despite that, the second trimester, we take the patient to surgery. So surgery, thyroidectomy, is reserved in this country for pregnant patients with significant Graves' disease, where the second trimester we take them to surgery to cure it because we can't use radioactive iodine ablation. So if the patient has very mild Graves' disease, and you can control it with very low doses of propanolol and PTU, that's fine. You could hold off the surgery, but the case that they're going to give us on the boards is the patient, despite small doses of propanolol, decent dose of propanolol, PTU, they still have symptoms. That patient, I told you, you can't increase the doses of the propanolol and PTU because you may harm the fetus. So what do? The second trimester, you take this person to the surgery. So that's Graves' disease. Now let's go on the other side of the hyperthyroidism syndromes and talk about this disease called toxic multinodular goiter. Now, toxic multinodular goiter is non-autoimmune. It's not autoimmune disease. It's a consequence usually of a simple goiter for reasons people don't understand. Usually you have a simple goiter that is non-toxic. Non-toxic goiter in thyroid disease usually means it doesn't secrete anything, right? A non-toxic goiter, and then years later, 5-10 years later, it becomes toxic now and it starts to secrete thyroid hormones. So that's a toxic nodular goiter, and most of the times it's multinodular. You have multiple nodules, not one. So on exam, you feel a nodular goiter on exam, a lumpy, bumpy thyroid. That's what you feel, versus the diffuse thyroid enlargement that you see in Graves' disease. Now, this is usually a disease of the elderly. Older people get this. The comparison is Graves' disease, where younger patients get this. The presentation is not the typical hyperthyroid presentation. They don't always lose weight. They don't always have the tremors. They don't always have the diarrhea and stuff like that, the typical, and they definitely don't have the ophthalmopathy. They never have the proptosis, but they don't have the rest of the typical symptoms of hyperthyroidism, toxic multinodular goiter. Nobody knows why. They typically present in older patients with mostly cardiac manifestations, either arrhythmia, especially atrial fibrillation. So please, if you see a new onset atrial fibrillation in somebody, especially if they're older, think about hyperthyroidism, think about toxic nodular goiter. And then the other one is congestive heart failure that present with this high output heart failure. Now, patients that are older also have a lot of comorbid conditions. So they have other coronary heart disease or hypertension, and now they have the high output state, and it puts them in heart failure. As I said, there's no ophthalmopathy in these patients. So if they give you the 60, 70-year-old patient with hyperthyroidism who had a non-toxic goiter in the past, they tell you, I had a normal goiter, my doctor told me it was okay for a long time. Now they come in with symptoms of hyperthyroidism, they have toxic multinodular goiter. That's the diagnosis. The treatment is a lot like Graves' disease. The definitive treatment is radioactive iodine, just like Graves' disease. There's really no difference in this case, so they're managed for your purpose, they're managed the same way. Now, I told you one of the reasons why we are afraid and we want definitive treatment of hyperthyroidism is this thing called thyroid storm. It's a very extreme form of thyrotoxicosis. It's not just bad hyperthyroidism, but these patients usually present with delirium, coma, they have hypotension, they have heart failure, they have high fever. Only patients that fit into this category are diagnosed to have thyroid storm. So thyroid storm is a definitive, it's a very specific diagnosis, not somebody that has just bad hyperthyroidism. They have to have some kind of CNS manifestations. They usually have cardiac manifestations, especially hypotension and heart failure, and they have high fever. That's thyroid storm. The reason why it's only these patients is because when you say this patient has thyroid storm, it has to be treated in a specific way, and they carry a very high morbidity and mortality in these patients, very high mortality. Now, these patients are usually people with Graves' disease that haven't been managed well, and then another probably precipitating cause occurs on top of that. Something like surgery, they take into surgery without knowing that they have hyperthyroidism, or they have some kind of other stress like sepsis or trauma, something like that. Something tips them over. So they have Graves' disease that's not treated well, they're not taking their medications, or they're not following their doctor, or their doctor's not managing them well, and then something else occurs in these patients to tip them over into this thing called thyroid storm, which carries a bad prognosis. Now, once you've made the diagnosis, it's a clinical diagnosis, right? I told you they have to have CNS manifestations, cardiac manifestations, and high fever. That's typical. Fever usually in excess of 104. That's the typical fever that patients with thyroid storm have. That's not the typical fever that people with infections have. You don't usually see in excess of 104. It's very rare to see something like that with infections. Once you've made the diagnosis, the clinical diagnosis, you have to treat this patient, and the treatment is very much like Graves' disease, but a couple of extra things. So the bottom line is, the treatment of thyroid storm is they get the antithyroid agents like PTU or methimazole. Methimazole probably works a little bit better here because I told you the conversion of T4 to T3 is blocked in the periphery. And they get some beta blockers, a lot of beta blockers. Even though they have heart failure, beta blockers is the way to go. So they get the typical treatment for Graves' disease. And now they get a couple of other things. One of the most important things that they get is iodine. They get iodide. Now, iodide, when you give iodide to the thyroid, what it does is it stops producing active hormones, and what it does is it starts to incorporate iodine into the cell to make hormones later. So you're basically buying yourself some time. So you're down-regulating the thyroid cell by giving them iodine. Sounds kind of like paradoxical. You know, why would you give the thyroid cell iodine? But what it does is it shuts down for a while, basically to incorporate iodine into the machinery and make more thyroid hormones a couple of days later. That's the concept. So once you give this patient anti-thyroid medication, beta blockers, and iodine, that's the cornerstone of treatment of thyroid storm. Now, a couple of other things that we give them, and people always ask me, they get a little bit confused. We give them a lot of IV fluids because they're hypotensive and they're dehydrated, and we give them cooling blankets because they're running high fevers and stuff like that, and we give them dexamethasone, corticosteroids, and the reason is we give corticosteroids in all severe forms of thyroid disease. So don't get caught up in that. It's not a big deal, but we give corticosteroids in both severe forms of hyperthyroidism and severe forms of hypothyroidism, because you really need normal thyroid function to basically metabolize and utilize your corticosteroids. In this case, probably there's also increased breakdown of corticosteroids with the thyroid storm. So dexamethasone corticosteroids are used, but they're not the cornerstone of treatment, right? This is adjuvant treatment, along with the cooling blankets. So what's the most important stuff here is the iodide, the anti-thyroid agents, and the beta blockers. Now, I said iodine is very important. I didn't say it works first. There's some other stuff. The beta blockers probably work earlier. The anti-thyroid medication, methimazole, probably works earlier, but the iodine is very important because it downregulates the thyroid cell, and it's very important because they ask us about it, because it's a kind of like a paradox. Why would you be using iodide in thyroid storm? So again, iodine, beta blockers, and anti-thyroid agents, the cornerstone, and then some additional stuff, dexamethasone, IV fluids, and cooling blankets is the treatment of choice in thyroid storm.